guest speaker of the day, Ari. But beforehand, allow me to read her curriculum vitae. So, Ariel currently serves as the liaison officer to governmental and non-governmental organizations AMSA International 2023 and 2024. She has also recently won first place for the Indo-Pacific Global Health Case competition, hence becoming Asia's representative in the Emory Morningside Global Health Case competition in Atlanta, United States. Locally, she has also been deeply involved in various medical student-led activities. So let us welcome Ari. Ari, how are you feeling today about today's session?
Hi, Saray. I'm very excited to share with you guys what I prepared and what Sydney has also told me to prepare for today. I hope that it can be a great insight for all of you.
It will sure be great. Thank you again for joining us. It's like a great pleasure. So before we begin, also, I would like to once again remind all of you that we will open the floor to the audience later after the talk. If you have any questions for our guest speaker, you may type your question in the Zoom chat features or directly turn on the microphone. So, Ari, now the screen is yours.
Okay, thank you so much, Saraya. Let me just share my screen. Okay, is my screen visible? Okay, let me start. Good afternoon, good morning to everyone here, wherever you are located. I'm Ariel Yumisanunata. I'm currently serving as a liaison officer to governmental organizations and non-governmental organizations of AMSA International 2023 to 2024. So before I get to what I'll really be presenting today, I just want to give a quick introduction to, I don't know, my credibilities, I guess, to bring to you the topic for today. So as Sarayan's mentioned, I have participated in a global health case competition. So maybe some of you might be wondering, what is a global health case competition? It's an experiential program that brings together students from multiple disciplines to address a critical global health challenge. Now, this competitive case competition requires student teams to work collaboratively, people from different disciplines to develop solutions designed for health impact and present a business case to an expert panel of judges. And being the first and only lower middle income country to have ever won the competition sets a benchmark for a lot of Asian countries, for a lot of Indonesian Pacific nations. And this offers a blueprint to tackle health-related issues that resonate deeply within my communities in Indonesia, such as childhood malnutrition, child mortality, climate change, and many other issues. So I've been blessed to be able to join two of these competitions, one hosted by the University of Melbourne in Australia, and the other by the Emory University, or the Emory Global Health Institute in Atlanta, United States of America. So I'd like to tell you a story. In the kitchen of her Arorai Island home in Kiribati is an Asia Pacific island located in the Pacific Ocean, a bit east to Australia. Aulani prepares spam fried rice. This is a stark departure from their usual fresh fare of tuna and maybe cassava. Devastated by a recent flood exacerbated by climate change, Alani and her husband, Kekai, struggle to provide for their family. And their once thriving garden has been destroyed, their medical expenses are draining their finances, and their meals now consist of canned goods and processed foods. And as Alani prepared meals for her family, Kekai, her husband, helped their son, Ahohako, who is 7 years old, with his reading that is below his grade level. So now you kind of start to see the problem. But what has really kept Alani sleepless on most nights is her children. Her 2-year-old daughter, Eiwera, just fell ill with cholera after the recent flood, and her son is almost always hungry. and malnourished. He is still the shortest among his classmates despite his growth spurt. And Aulani can only comfort her hungry son, and she's very burdened by the weight of her dire circumstances. This is the condition that a lot of Kiribati people encounter. And the next day, Aulani finds solace in her children receiving school lunches to combat malnutrition while she sews garments to sell in the market. And despite her husband's reassurances, Aulani confronts the harsh reality of her children's suffering. And as she's desperate to provide for her family, she sells her goods in the markets and encounters other women in Kiribati who share similar struggles. But an opportunity arises. They decide to turn to Kiribati Climate Action Network, or Kirikan, and Aulani sees a glimmer of hope. So as she shares her problems with this organization, Aulani and her community voice their struggles with poverty, hunger, and the impact of climate change. And this interaction sparks a newfound sense of optimism as they hope for change on the horizon. And Kirikan heard them, and an opportunity was provided. So, following the Kirikan's president's meeting with UNICEF Pacific Islands, a unanimous decision was made that greater efforts need to be made to safeguard healthy childhood development across Kiribati, and with a particular focus on childhood malnutrition. So listen up. UNICEF Pacific Islands is pledging a 2-year grant of 2 million Australian dollars to support innovative interventions that will improve childhood nutrition and reduce childhood mortality in the island nation, and is currently seeking proposals. What are the details of it? All the participants here in the Zoom meeting today are a team of international childhood development specialists who has been contacted to work on this proposal. Now, you've previously worked across the world and have successfully improved the state of childhood development in various low-resource settings, and this grant will help support a lot of children growing up in Kiribati, and you know that it is an opportunity that cannot be missed. So this is what a global health case competition, this is just a tiny taste of what a global health case competition would look like. And what UNICEF Pacific Islands is looking for is a solution that addresses childhood nutrition, identifies a specific measurable metric, provides justification for this choice in metrics, and the solution must be evidence-based and tailored to the target audience's feasibility and cultural appropriateness. And the intervention has to build upon existing initiatives or create a novel approach, and considers existing school and community programs. Next, the program has to recognize the social determinants of health and childhood development, and particularly nutrition, and collaboration with local stakeholders is highly encouraged. So we know the social determinants of health: education access and equality, healthcare access and equality, neighborhood and built environment, economic stability, as well as social and community context. The next criteria is that this is a 2-year community-based project that builds local capacity, and you must ensure that the benefits continue after the project ends. You must leverage community resources, obtain members' buy-in would be critical, and you need a clear timeline as well as a consideration of sustainability. The next criteria is that the $2 million given to you by the UNICEF Pacific Islands can be spent on any aspect of the program. And expenditure of the $2 million needs to be budgeted, clearly justified, and fully expended in 2 years. Now, 2 million Australian US dollars would equal to about 1.3 million US dollars, to give you a better idea. And lastly, it has to be a targeted intervention. It has to focus on intervening during one specific time period in childhood, either infancy, early childhood, preschool age, or pre-adolescence. And you must add a rationale to that. The proposal must adhere to ethical and cultural considerations, and include a detailed budget and demonstrate a clear understanding of the present issue at hand. Now, being childhood development specialists, you ache for the well-being of Kiribati children, and you truly believe that Aulani's children could have received better. You've got compassion for these children and the passion for population health, but sometimes just having the passion for it isn't enough. You have to do something. But the question is now, where do we even start? public health issues are very complex, and that is exactly the reason why I'm so passionate about AMSA International as well as global health and public health, because it stems from the understanding that treating a disease is just one aspect of health, and anyone can be infected by a virus, for example, the COVID-19 virus, but survival after being infected by the virus would depend on the person's immunity, and that is shaped by what food is accessible to the person, how's the water quality of the person, what's the daily air. And these are all social determinants of health that are determined by health policies and social norms. And us, AMSA International members, future clinicians who understands best a disease pathophysiological process, it aches me personally to know that maybe prescribing drugs may never address the patient's living condition, and there's a wider set of systems and forces beyond the confines of medicine, and this is exactly what public health and global health is about. So let's get into this journey, this complex yet fulfilling journey to address Kiriba's pressing issue of childhood malnutrition and mortality, even if it's just for pretend. And who knows, one day we'll become doctors, creating macro level impacts on healthcare too. This is just an outline of the thought process that I personally experienced and went through as I prepared to solve public health and global health issues from the competitions that I've joined. Okay, first is analysis. When we look at a problem as complex as a public health crisis, our best bet is to chunk all the different aspects that may affect it. And a foolproof tool to use would be an issue tree, or otherwise known as a problem tree. And what this does is break a problem into digestible pieces and helps us look at the problem more comprehensively. To build our issue tree, several aspects related to a health system's building blocks may be useful to assess. So the WHO has defined 6 building blocks of a health system. First is service delivery, which ensures provision of effective, safe, quality healthcare services to meet population needs. There's the health workforce, and then there's also health information systems, which is about the collection, analysis, and the use of health data for decision making to monitor health trends, to evaluate the performance of a health system. There's also, this includes health information technology infrastructure, data standards, mechanisms for data sharing, as well as reporting. Next is access to essential medicines and technologies. This block focuses on ensuring access to affordable, safe, effective medicines, vaccines, diagnostics, and medical technologies. And then there's also health financing, which addresses the mobilization, allocation, utilization of financial resources to fund healthcare services. And lastly is leadership and government. This block includes the overall stewardship and governance of the health system. And now this includes setting strategic priorities, establishing policies and regulations, as well as coordinating stakeholders. These are just some of the building blocks that you can use to assess the problem that is at hand, especially in Kiribati. And this right over here is a guideline by the WHO. It's called Health System Performance Assessment. If you guys are interested, you can just search it out on Google. And for me, it's very interesting to read into it because it serves as a framework for policy analysis of many nations out there as they try to evaluate what can be improved with their health system. So let's take what we've learned, the issue tree and the health system assessment in action. It should be doable. It sounds pretty simple. So let's try to break down the issue of childhood malnutrition that we've received in Kiribati. Okay, so when we look at it at a glance, it should be pretty obvious that childhood malnutrition has at least 2 dimensions to it. The dimension of the child's nutrition as well as the child's health. The case did mention Aulani's daughter having cholera and Aulani's son being severely stunted compared to his classmates. But as clinicians, we also understand the social determinants of public health. So we can also include the problem of water and sanitation, education, as well as social protection, because these might affect a child's growth and development too. Let's take that a step even further. And as we delve into a deeper and deeper research, we can try chunking some of the smaller sub-issues. There might be an issue of poor healthcare accessibility due to the very few healthcare facilities available in Kiribati. And did you know that complex medical cases in Kiribati are actually referred out of the country to the neighboring islands of Fiji? So that just goes to show the condition of Kiribati's healthcare system. There's also a lack of transportation between islands because it's an island nation. There might also be the issue of inadequate health financing. With people's mouths to feed, it seems as though the government would choose to allocate their money to fill the stomachs of Kiribati people first, rather than improving their health facilities for a long-term benefit. And now these are just some of the issues that we might find as we enter the deep rabbit hole of our research of the country. And so an all-encompassing issue tree might look like this. It may look complicated, but now we can visualize which root problems that would be feasible to tackle. Okay, now as a disclaimer, before I get into this diagram, for presentation and pitching purposes, you'll see a bunch of diagrams that will probably make you think, wow, this must have been so time consuming, and it actually is. But we want to be able to communicate our ideas, arguments, and solutions to people from an array of fields and backgrounds, or in this case, the stakeholders from the UNICEF Pacific Islands, the president of Kirikan, and the Kiribati government. So what this diagram shows is the different issues in our issue tree previously that's mapped across different age groups. And what this diagram shows is the assessment of impact when we tackle those issues in different age groups. So the one in green would have the highest impact. Okay, and your working document might not look all pretty in that diagram format. Realistically, this is what it would probably look like. A spreadsheet with a lot of rows as you jot down the different issues contributing to the dimensions of childhood malnutrition, as well as each of their burdens. Now, where did we get those numbers, like those 20%, 31%? These are from official documents that are actually released by Kiribati Ministry of Health, as well as NGOs that work there. So now that we've mapped them out, we've analyzed the problem, it's time to strategize. Where do we want to tackle? A public health model that I really love is Hugh Taylor's leaking pipe model of care. So a little background story to this is that in 1976, Professor Hugh Taylor, he's a professor from the University of Melbourne. He spent a year working as a part of an Australian-wide program which assesses and provides eye care to Australia's Indigenous people. And at that time, the rate of blindness for Indigenous Australians rate was 10 times higher than that of non-Indigenous Australians. Now, a number of programs and initiatives were started that had some impact, but no major or long-lasting changes were affected. And in 1996, Professor Taylor was asked to create a report for the Australian government on the eye care needs of Indigenous Australians. And what he found is this leaking pipe of a healthcare system. So this problem could have easily been filtered or tackled in the early stages in the community level. But because there was no action early on, more and more patients progressed, becoming worse and worse and worse, until finally they have to reach the tertiary clinic level and have to undergo a cataract surgery, while they could have done a lot of preventive measures early on if they had been intervened in the community. So oftentimes this model emphasizes the importance of a preventive and upstream approach. So let's take that Hugh Taylor's leaking pipe model of care and apply it to the diagram, the analysis that we made earlier. So through this assessment, as you can see, it has the most number of icons here in the infancy stage and the most number of green impacts. So it indicates that it has the highest impact if it was tackled through the infancy stage. And so it was clear that in order to have the most significant impact on Kiribati's future, we must target the earliest age group. And this is also backed by evidence. Early childhood is a critical period of rapid growth and development. And so malnutrition during this time can have long-lasting and irreversible effects on physical, cognitive, and social-emotional development. So you can also notice that in every step that we do, we must also always refer to evidence that we have at hand. Okay, the target age group has been identified, but what dimensions do we need to address? Because so many factors affect health quality, yet we can only do so much within 2 years and with a budget of 2 million Australian dollars. And to achieve the widest impact, we must identify cross-cutting themes. And these can be gender equality, diversity, and inclusion, etc. For example, a project addressing climate change resilience may also improve the health and incomes of local farmers. So that's just one example of what cross-cutting themes might look like. So as we discuss childhood malnutrition, many dimensions exist, including health nutrition, education, water and sanitation, social protection, etc. But our analysis has made it clear that it would be best to tackle the cross-cutting themes of health inaccessibility and food insecurity, because we also recognize the issues of poverty and climate change. And with that, we start to get a picture of the objectives that we're striving for. And recognizing the complexity of these issues, it would be best to adopt for a strategic and multidisciplinary approach. Okay, now we've got the objectives, we've got our strategy. What next? Now it's time to get all ideas cooking through brainstorming. So innovations actually don't have to be disruptive. There are so many dimensions and natures of innovation. Okay, for example, natures of innovation. Right here, over here, there is product service innovation, process innovation, and business model innovation. For example, a product or service innovation is developing new products or services. For example, the iPhone is an example of a product innovation because it revolutionized the way people communicate. But in public health, this can look like evidence-based practices such as those recommended by community guidelines. Next is process innovation. This refers to the change in the way products and services are produced to improve efficiency as well as quality. In public health, maybe there's a move towards quality improvement methods, a plan, do, study, act, or other improvements in the way that things are processed or manufactured. And lastly, there's the business model innovation. And this refers to the changes to the basic nature of an industry. Another dimension, aside from the nature of the innovation, is also the degree of change. Are we adopting something? Are we creating something new? Or are we disrupting the existing status quo? So as you can see, innovations don't always have to be disruptive. For example, an innovative innovation, for example, maybe it's a health department adopting a PHAB accreditation, and an incremental innovation would be implementing fresh ideas, usually resulting in small changes to what already exists, while a disruptive innovation would be at the higher end of the spectrum, and it changes or reshapes an entire industry. So these are just some of the examples of what an innovation can look like from a theory's point of view. But what's super cool about bringing tangible improvements through innovations in public health is that we're able to stand on the shoulders of giants through best practices from around the globe. And this is my personal favorite reference. I'm just going to send this to the chat. I love reading through this because this website actually gives access to a lot of articles from different countries around the world as they implement public health innovations in their own countries. And maybe we can learn a thing or two from these countries as well. But of course, contexts differ from country to country. But fear not, because public health has also provided a cheat sheet for you to assess program transferability through cluster analysis. Now, I'm not really going to go into the depths of this, but if you guys are interested in learning more about this, you can just search up cluster analysis or public health intervention transferability, and it should pop right up. Okay, so what would brainstorming and action look like as we assess back our case of Kiribati childhood malnutrition mortality? So the current referral system, the current health system in Kiribati looks like this. There are health clinics, health centers, referral hospital, and national referral hospital. And the thing about these health clinics is that they don't exist in every village. And so it's quite hard to access a healthcare facility in their day-to-day lives. So let's say we propose a new innovation to their health system. We create community health centers. We know that community health centers or primary health centers exist in a lot of countries in the world. For example, in my own country, in Indonesia, we have something called Posyandu, and it has really helped in creating community referrals and early flagging or screening that will aid healthcare decision making in primary healthcare centers. What do we want these community health centers to achieve? We wanted to engage the community and empower them. We wanted to also become an infant health service provider, and we also want these community health centers to have monitoring functions. So what can we do? We can reference several existing infant community health centers worldwide, especially in developing countries. And we know of several programs, such as the Primary Child Care Day program, which includes measuring the height and the weight of infants, of babies, the formation of community health workers so that we bring care closer to communities, and also infant health handbooks that will aid mothers in overseeing their child's growth and development. And a lot of evidence can back these programs up, such as the Primary Child Care Day program references. It has been put in many guidelines, this one from WHO. Community health workers, they also exist in so many countries in the world, especially lower middle income countries. And the WHO has also recommended the adoption of the strategy, as well as maternal and child health handbook references. There's actually an international guideline for this from GICA. So it has also been proven to have worked in a lot of countries. But then, of course, Kiribati is an entire whole country on its own. So we must contextualize our programs in that country. And what we want to pay attention to are 3 points. First is community engagement, second is stakeholder collaboration, and third is cultural competence. Now, these 3 points are vital for creating impactful public health interventions because they provide insights into local context, and this will allow your interventions to be tailored to cultural norms and values, making it more acceptable and more effective in the communities. And you can also involve community members and stakeholders in the planning and the implementation so that you are trusted and you are credible. And this will enhance intervention uptake as well as sustainability. So on the right over here is the theory of reason action. What is the theory of reason action? It's a popular theory describing the way people behave, especially in health behavior. And one interesting thing is that there is an aspect of behavior called subjective norms. So simply put, subjective norms are a motivation to comply to a certain behavior that doesn't come from within. It comes from people called reference individuals, or the people that you think are important, the people you think their approval or disapproval would be important and would affect the way you behave. And this is a very important aspect of health behavior because by engaging people who are reference individuals and communities, you will have a very sustainable effect in the interventions that you're going to make. For example, an elder that is well respected in that community. Next is stakeholder collaboration. So here on the right is another theory. I'm bombarding you with a lot of public health theories today, but this is actually a business model the Public-Private People Partnership, or the 4P, which is a collaborative approach that involves the participation of the government, the private sector entities, and the civil society. And it addresses societal challenges and deliver public goods and services. And how it's related to health is that this also aligns with the mixed financing approach that a lot of countries have regarding their health system, which combines government funding with private sector resources. And by utilizing this partnership, we will also be able to create a program that can access more people, that can reach a wider audience. And lastly is cultural competence, which if we recognize it and we truly understand it, this can foster trust and engagement between us, international childhood development specialists, with the community. What does this look like in a Kiribati action plan? It can look like this diagram, for which we collaborate with a lot of partners such as Onaine and Unamwane. They are elders or respected community members in Kiribati. This can also look like creating activities for these health interventions at Manayabas or the meeting house in every Kiribati village. It's the biggest building in any village. It's the center of village life, and we can definitely utilize the space to implement our activities. It can also look like recruiting local women to become community health workers so that we ensure community engagement and empowerment. It can look like working with Kirikan and as well as the Ministry of Health and Medical Service. These are just some of the examples that we can do as we implement our project. Now that we've got our plan set out, let's talk about the logistics. First, timeline. We've got a 2-year period. Now, I'm not going to go into the details of how this program will be implemented, but some of the key points that I've come to learn from preparing a timeline for a public health intervention is that it's always best to insert a period of time where you would dedicate it to do research about the community, about the people you'll be facing, about the resources that exist, because of course you can't really look at the actual situation when you're just researching it online. There's also this thing called leveling, where we test out our programs in phases. We start by creating a pilot project. Now, a pilot project is designed to test things out on a small scale before knowing if it will be viable, if it will be a viable option for us to continue in the future. And a lot of businesses use pilot projects testing, like they test new softwares with pilot projects. And the same goes for a public health intervention. For example, in Kiribati, with their 79 villages, we could start by creating a community health center at one of the Maniabas in one of their villages first, and we will do monitoring and evaluation to see if it will be feasible for the long run. Of course, this is a very simplified scheme of the timeline that was actually prepared for this program. Next is the budgeting. This is also another simplified scheme of the budgeting plan, but several things to note here is that you might see over here there is a budget buffer, which is money that you don't intend to use for you when you go off track with your spending, and this provides some security and cushion for your budget. It's very important to have a buffer because you don't know what kind of unexpected events might happen on the field. And what I also want to note over here is that it's actually not shown here, but in a lot of cases, there have been debates on whether we should incentivize community health workers with monetary benefits. Should we pay community health workers? Because in a lot of countries, community health workers work on a volunteer basis. And there have been lots of arguments about it, lots of papers as well about the topic, but the bottom line is you cannot really always demand people to work for you based on their willingness to give back to the community, for community betterment, especially because these community health workers also come from the community that is experiencing these problems. So it's best to also include incentives for all the people involved in your program. One of them being monetary incentives for the community health workers that you've prepared in the program. And how we can decide upon the allocations of budgets with our 2 million Australian dollars grant is that we can refer to the way health is financed in that country and existing resources allocation. So thankfully, Kiribati has a lot of resources online, which transparently shows how much they allocate for existing programs or how much they pay their workers with different backgrounds and expertise. And that information is used to create the budgeting plan as well. Okay, now with the logistics, we've got project implementations done. We have our plans. Our project is absolutely ready. It just needs to be implemented. But we can't forget the aspect of sustainability and program impact, because this is what will make your program differ from every other program out there that has been done before but failed to address the critical situations at hand, failed to last up until now. And this aspect can actually be done from a very early stage if you keep the aspect of sustainability in mind from the very start when you design these programs. So the way you can ensure sustainability of the impact after program exit, after your 2-year period ends, or maybe in any other NGOs, after you're done with your program, or maybe in your local global health subsidiary, you create a program and you want that impact to last even after you leave the community, you leave the place, is by implementing an exit strategy. So an exit strategy is a plan that outlines how an organization or entity will gradually withdraw its involvement in a project or intervention. There is a transfer of responsibilities and ownerships to a local stakeholder or other relevant entities. There are 2 types. There's phase over to other stakeholders, and there's also phase out when you run out of resources. And in public health interventions, it's crucial for sustainability by promoting local ownerships, building capacity. This also ensures continuity of services. It facilitates the integration into existing systems, and this also maximizes impact. So what an exit strategy would look like is thinking, how will this program run when I've left this place, when I'm not there anymore? You can talk about the financing of the programs, the compliance of the community, and the program dependency. For example, in finance, will the government fund this program after you've exited the program or after that 2 million Australian dollars grant has been finished? And then there's also compliance. Will my community health workers want to continue on working for Kiribati communities after we've exited from the scene? As well as program dependency, will this program continue to exist even if we're not there? And by thinking of these things, we can shape our program so that its sustainability can be ensured. So, for example, we've educated these community health workers. We've incentivized these community health workers. So yes, we can ensure community health workers' compliance even after this program has ended. At the very least, these communities will be left with a lot more knowledge than they had before we entered the scene. And then another aspect is to also conduct a risk analysis. A risk analysis will help to identify potential challenges and obstacles that may arise during the implementation of a public health intervention. And by anticipating these risks, we can proactively develop strategies in mitigation strategy, a contingency plan, to address the risk and minimize disruptions or maybe delays. What this look like might be something like this. So maybe we can see over here. Okay, what if there's a low number of community health workers applicants? What if there are no community health workers that can be recruited? Then we can have a mitigation strategy or a contingency plan. Okay, we can partner with these respected elders to recruit local women or local people to become community health workers who can incentivize them through monetary benefits. And we can also do a close recruitment of community health workers from existing NGOs that work in those communities, such as Kirikan or even other partners. That is what a risk analysis might look like. And after that, it's also very important and crucial that after everything that's been done, we continuously assess the program impact with monitoring and evaluation. So here I've actually taken reference from the Global Health Subsidiaries report template, which I find to be very comprehensive as well as useful to assess a public health program effectiveness as well as sustainability. I'm pretty sure you all are familiar with this report. And this can also be implemented in monitoring and evaluating a public health program that's done anywhere. So some of the criteria that I actually like to use is the social determinants of health. Okay, so the case might have actually required us to refer to the social determinants of health, but I find it extremely useful that it's also used to measure the impact that we have on our Kiribati communities, be it a quantitative impact or a qualitative impact. So one thing that I've learned or received feedback from is that your measurement, your quantitative measurement, should not only be phrased as, okay, number of jobs that are created for local women, but you expect these number of jobs to be increased or decreased. In which direction do you expect it to go? And it's also very useful that you don't only have a quantitative outcome from your program, but you also have a qualitative one, such as increased knowledge, increased healthcare facilities, increased compliance to health interventions, increased capable healthcare workers, or a healthcare built upon community support. Over the next 2 years, the program that we've made together in this short period of time will be able to achieve specific goals, such as expanding early infant malnutrition screenings, enhancing knowledge through the use of infant health handbooks, promote healthy infant complementary feeding practices, and ensuring the continued presence of community health workers to facilitate these initiatives. And the ultimate objective is to improve the overall quality of life for infants in Kiribati. Okay, I'm nearing the end of my presentation. So Alani's children might not have received the food, care, or future they deserve. But with the program that we've come up, these children will receive the future they deserve with the community health centers that we've built. And mothers, not only Alani of Kiribati children, will now rest assured that their very own communities are joining hands to create a brighter landscape to safeguard Kiribati's future, which is their infants. And finally, that is all for my presentation. I hope that this short case study, as well as some theories that I've presented, can help you and guide you to create your own impactful public health projects in each of your chapters in each of your local universities, wherever you are. And I hope that UMSA International will continue spreading its impact in a lot of areas in public health. Thank you.
Thank you so much, Arif, for this amazing session. And with that, the webinar session has come to an end. But before that, we're going to open a Q&A session for the participants. So if you have any question for our guest speaker, you may type your question in the Zoom chat picture or raise your hand if you would like to voice out your question. Wait a bit. So actually, I have received a question. So the question is, Ari, with your knowledge from the resources you have, do you think health checkup, which are often done as a local public health project, are actually evidence-based and impactful? And is there anything better than like health checkup?
Okay, so yes, I recognize health checkups to be the most used public health intervention here. And in a lot of places, in a lot of countries or villages, if we assess the current condition well, then yes, it is actually very useful to still be doing these health checkups because there aren't a lot of human resources that may exist in that certain community or village to be updated enough with the current condition or the health data in that area. But sometimes I personally think it's way too overdone, especially when we're doing a big event, for example, an organizational event, and we think, oh, I think one of the simplest ways to approach this community service would just be doing a health checkup in a place where health checkups are actually done regularly. So yes, it might still be relevant in a lot of places where human resources for health are not available. But I think one of the ways we can do it better is we think about how we can integrate that health checkups with existing systems. Because, for example, we host a health checkup and then the community members receive the result that, oh, my blood pressure is high, my blood glucose level is high, but then that's all. We as medical students cannot really prescribe them with medicines. We can't monitor if they're actually checking it up regularly. So what we can do is think a step further and ask ourselves, how can our health checkup be integrated into the health system that exists in that area, in that village, in that community? So one thing that I love to do when conducting a health checkup is to collaborate with the local primary health center there and actually receive support from the primary health center. I come to them and I ask, is there anything that we can help you with? Are there missing health data that maybe we can help you with? And some of the health checkups that I've done is from some of them, I've learned that they can actually provide referrals to the primary health centers where these people will be then able to do a follow-up to their results from our health checkups. And in some villages, I've also encountered primary health centers that are missing a lot of data, that are actually trying to transition into health digitalization. And with our health checkup, we were able to integrate written data into their system that they're still trying to manage. So there's a lot of ways that we as students can actually help integrate health checkups with their existing systems. And it only takes us a simple step to ask, to reach out to them, to these primary health centers that encounter these people daily. What can we do to help you? Instead of just doing a health checkup and leaving it just be. Of course, we want to ensure sustainability and long-term impacts of our programs. So I think that's a simple way to do one step further of a normal health checkup.
Thank you so much. We have also another question that came up. So as a medical students, we do not have, of course, we don't have a high budget. $1 million is quite a lot for us. So from your experience, how will the percentage of budget allocation look like?
Okay, so from my experience as a medical student, we do a lot of what do you call it? Raising funds. Yeah, we do a lot of fundraisings in our own communities. But what I've come to realize is that aside from these small fundraisings that we do, it also just takes us a little step further to reach out to partners out there who would be willing to work on the same objectives as we do. If we as medical students want to better the health of our communities, there also exists GOs and NGOs out there that would also like to better the health of our communities, and they would have a better access to resources that we medical students might not have. And it doesn't have to be monetary resources. It can look like speakers that they can provide. It can look like test health kits that they can provide. And these are just some of the ways that we as medical students can allocate our budget to some other pressing needs. Maybe it could be transportation, it could be food for the people there. And I think that every people here has a lot of experience already in allocating budgets for their own local public health programs. But yeah, that's just an additional tip that I've come to learn after several years of making these programs, that there are actually a lot of people out there who have the same compassion for communities as we medical students do, and it won't hurt to try to reach out to them as well.
Thank you so much. I have one last question. Actually, it's like from me. It's like this project itself seems very there's a lot of information and a lot of things to do, to search, to contact. So how did you like work on this project? And also, you also have your medical classes, examination, quizzes, and everything going on. So how do you like organize yourself without being overwhelmed?
Okay, so I personally think that every medical student here has a personal dream that they want to achieve. Maybe it's to become a clinician or a public health advocate in the future. And I think this is just one of the ways that I express what my dream is. To work at UNSA International, to work closely with people who are just as passionate as I am about global health and public health. And I think this is the ways that I express it in terms of how I am able to organize my time and my energy. I'm grateful that my university supports me in joining these programs and joining these competitions. And I myself have had a lot of sleepless nights, I can't lie, preparing for these types of competitions. But I think that in the end, everything becomes worth it, because I know that this is what I'd love to be doing in the future. Maybe not everyone would go down the path of being a clinician in this Zoom meeting. It can look like creating a more tangible or a wider or a macro level of impact to healthcare through public health policies, through public health programs. And I think that all of this is just part of an exploration of what we really want to be of, or what we really want to do in the future. I think that's my answer.
Thank you so much. Also, thank you everyone for your wonderful, interesting questions. But Ari, before we let you go, we would like to present you an e-certificate as a token of appreciation. So we would like to take a quick picture with you. So Samuel, please, for documentation.
Okay, I'll be taking the picture. Okay, in 3, 2, 1. Thank you.
Thank you.
Once again, thank you very, very much, Ari, for this wonderful session. It was truly very captivating.
Thank you so much, Soraya. Thank you to the Global Health Subsidiary for having me here.
Oh, thank you for joining us. So this is the end of the Global Health Masterclass. Thank you very much for your active participation, everyone, and enthusiastic response. We hope you had a great time learning about public health projects, and you are now empowered to implement new knowledge into practice in your local communities. First, before you leave, we would like to ask everyone to please scan this QR code to fill out the feedback form. We are also looking forward to seeing you participate actively on the upcoming initiative of the Global Health Subsidiary. But before we end the session, should we take a picture together? So everyone, please turn on your camera, get ready for a picture, and Samuel also please stand by.
Okay, please turn on your camera. I'll be there are 3 slides in here, so I'll make sure everyone will be included. Okay, for the first slide. Okay, for the first slide in 3, 2, 1. Okay, second slide. Three, two, one. Okay, third slide. 3, 2, 1. Right.
And maybe now with the AMSA sign.
Okay, for the first slide. Sorry. 3, 2, 1. Okay, second slide. Okay. 3, 2, 1. Okay, first slide. In 3, 2, 1. Right.
Thank you so much, everyone.